Good evening and welcome to Stay Home and Healthy, an online question and answer session for IBD patients. These are difficult times where many of us are worried about contracting COVID-19, are out of sorts by all the changes to our daily routines, work, diet, and exercise, and have a lot of questions, myself included. To answer some of those questions, I brought together a distinguished group of panelists. I'd like to introduce Dr. Richard Rood, professor and gastroenterologist at the Washington University School of Medicine in St. Louis. I'd like to welcome Dr. Yazaz Gori, assistant professor and gastroenterologist at University of Missouri School of Medicine in Columbia, Missouri. Dr. Derek Eckley, assistant professor and gastroenterologist at University of Nebraska. And Rachel Lawton Coleman, assistant professor and child psychologist at Cincinnati Children's Hospital. We'll start with a short presentation on COVID-19 and how it's affecting IBD patients, and the remainder and majority of the time will be used to answer any questions that you have. Dr. Rood?
Welcome, everybody. Next slide, please. Dan?
Trying. It's not advancing for me. There you go.
There we go. COVID-19 is a novel coronavirus that seems to have come out of the Far East. COVID-19 is a new disease caused by this virus and has not been previously seen in humans. And the important part of that is that since it is a new virus to humans, we don't have any innate immunity to the virus. COVID-19 stands for Coronavirus Disease 2019, and it's only recently been picked up in human hosts, at least as far as we know. SARS-CoV-2 is severe acute respiratory syndrome secondary to coronavirus 2. The virus that causes COVID-19 disease. Next slide, please. What are the symptoms of COVID-19? Most common symptoms include fever, shortness of breath, and cough. However, and this is where it becomes difficult for IBD patients, diarrhea, nausea, vomiting, and abdominal pain can be seen up to 20% of patients. So it can be difficult to tell who has and who does not have it, and getting people tested can be complicated. You need to pay close attention to changes in your own symptomatology. If diarrhea hasn't been a problem for you and you start developing fever and diarrhea and you don't have another cause for it, then certainly COVID-19 is in the differential. Next slide, please. So what can you do to prevent it? Well, certainly washing your hands for 20 seconds at a time, I think that's helpful. Telecommute, you know, at Washington University, we are doing telemedicine now, as most of my colleagues are doing the same thing. We're trying to keep sick people isolated. The other recommendation from CDC and the Surgeon General have been to wear a face mask. That's not going to prevent you from getting COVID-19, but hopefully if you do have asymptomatic COVID-19, which can occur, then it might keep you from giving it to somebody else. Obviously, practicing social distancing, 6 feet apart, keeping everything as spotless and clean as you can, and cover your mouth or sneeze into your elbow to try to keep things, and trying to keep your hands away from your face are all helpful. This is, in general, a respiratorily transmitted disease, although theoretically it can occur. It can be present in the lower GI tract as well. Next slide, please. Medications and immune suppressing drugs, obviously in our field, our patients oftentimes are on immune suppressing medication. That is supposed to control their inflammatory bowel disease. As we look at patients who are at risk for COVID-19, that could be a problem. And what is important about it is that immune compromised patients or immune suppressed patients are probably at increased risk for COVID-19, although it's not entirely clear that it is the virus that is causing all the disease in COVID-19, or whether it's the body's reaction to the virus that is causing the problem in COVID-19. So that I'll turn over to Dr. Eckley, who will take over from here. Dan, next slide.
Sorry about the lag. There seems to be like some time between when I click the slide forward and when it shows up. It's going to happen now.
First, again, my time to thank you guys for joining us and welcome you. And first and foremost, thank you, Dan and CCFA, for kind of putting this together as another way to kind of help educate our patients and hopefully answer some of their burning questions. I think this is a nice slide here that kind of splits out the medications into different groups that we use for our patients with inflammatory bowel disease. It's really nice kind of synthesis here, really coming from an expert group of international gastroenterologists and IBD experts that have met and kind of went through and answered, I think it was about 95 different clinical scenarios and questions, trying to figure out kind of what do we do for patients in these certain situations. The big take-home point is if you're doing well, continue taking your medications as prescribed. The one note that I would say is if you got to look at the steroids, so that would be your budesonide, your prednisone, methylprednisolone, kind of whatever version you're on. Yes, we don't want you on these medications long term. I think that's the generality that we say with all of our IBD patients, that it's something we try acutely to get you down in terms of inflammation and then convert to another medication. But I would forewarn you, just don't all of a sudden stop taking the medication. That could be a problem in and of itself and creating adrenal insufficiency. So make sure you work with your gastroenterologist to work on getting down on a prednisone to reduce your risk of contracting or worsening the infectious process. Next slide, Dan, please. While we wait, the other thing to take home is looking at the immune modulators, the biologics, the JAK inhibitors, is if you were COVID positive or you had the coronavirus, some of the medications that we tend to use, we may want to hold those medications. And coming from the expert panel, they've kind of suggested holding immune modulators for about 20 days. This is kind of our best guess thus far. Additionally, there's some recommendation if you're on tofacitinib and you are positive, holding that medication for several days, about 20 days is what they're saying, just because of the worsening symptoms that you could present with or an exacerbation. So again, work with your primary gastroenterologist on what should you do if you were to become infected. I kind of alluded to the steroids earlier. We don't want you to stop these suddenly because of that certain risk. There should be a tapering plan from the time that you get onto steroids initially. And I think that most of us are keenly aware that this is something that we would probably like to wean you down or get off steroids a little bit sooner, if at all possible, to hopefully mitigate any ongoing risk. The problem being is that historically, when we've looked at the SARS infection that was present kind of in the early 2000s, there were some complicating factors in patients on steroids. Next slide, please, Dan. In terms of In terms of children, it does appear, based upon the reports that are out, that children's symptoms tend to be less severe or more mild, maybe symptomatic and symptomatic carriers. We really do have a limited amount of information on our children, but kind of the generalities that I spoke about earlier about staying on the medication would also be a similar recommendation for our pediatric patients that are on medication for inflammatory bowel diseases, to stay on those as long as you're doing well. Additionally, patients or children that do have nutritional support or nutritional therapies, those should be continued as well throughout the course. Next slide, please. I think the next slide gets us to infusions. The big things for the IB or the infusion centers, the things that you should be asking. Now, there's various scenarios. You could be in a hospital or clinic setting to where you're getting an infusion. You may be at an outpatient clinical setting, or even having home infusions. There have been some people that are advocating for home infusions. If you're on a home infusion, I would continue with that and making sure you're continuing with your kind of recommendations for isolation and cleanliness that have been talked about earlier by Dr. Ruud. Other things that you may want to ask is, of your infusion center, is what are they doing to mitigate risks? And I know that from our institution at the Nebraska Medical Center, we're kind of following all these kind of bullet points here. We do have screening protocol, and kind of what we would initially define screening protocol is kind of questions, fevers, shortness of breath, cough, feeling ill, and if those things are present, we may ask that you be tested prior to your infusion to kind of help determine what we should be doing in this situation. Other things would be adequate social distancing. Now, I know our infusion center, they're all kind of separate private rooms, so that's already in place. Visitors have been restricted at our hospital, so that would be something as well. I did have a patient ask me about, I have a friend that takes me to my infusion center, can she go with me? And I just said, by all means, have her drive you, because that's your mode of transportation, but she should probably stay out in the car, just limiting further exposure to others in the hospital or at that center. And the other part about it is what personal protective equipment is available. I know starting last week, all of the providers, once we enter the hospital, have been asked and required, if you're in a patient care setting, to be wearing a surgical mask. I would hope that that's something that they're also providing to patients as well, but those would be things or questions to ask. And from here, I think I turn it over to Dr. Lawton-Coleman. Thank you.
While we're switching sides, I'll say a thanks as well. It's a pleasure to join. So we'll be talking a little bit about how stressful this experience is for everybody, and how difficult it can be, not just for patients overall, but particularly IBD patients or parents of IBD patients. These recommendations are general, so take them and tweak them as you feel like would be helpful. One of the biggest things that we're hearing from families right now is that they are inundated with news all the time. If they're home and they have a phone and they're not having the distraction of work like they usually might, it's very easy to get stuck in patterns of checking the news or checking Twitter or checking social media. And while a little bit of information is helpful, too much information makes us more anxious. And so what we're really recommending is that families set aside an hour time during the day where they do check-ins. Watch your news show that you want, follow Twitter handles that you trust, listen to podcasts that you like, and after we're out of that hour time frame, we're not going to check the news. I generally recommend that that's sometime either in midday or before dinner. We want to try to avoid checking the news and getting all that information right before bed, because that will not be helpful. The biggest recommendation that we have from a day-to-day basis is keep a routine. Keep a routine and structure and schedule as much as you can. Whether it's having meals at the same time or waking up and going to bed at the same time, that regularity including taking medication, is really important for minimizing anxiety. From a medication standpoint, planning ahead and calling your doctor, calling your specialty pharmacy, making sure that you have the supplies that you need will be very helpful. We think about why things like this are big and scary. It's because there's so much uncertainty and so much that's out of our control. And so taking control in whatever way we can, if it means calling and getting that medication delivery scheduled, or calling to get those infusions scheduled, or to get that information, all of that will be really helpful. It's always, always, always okay to ask questions. So if you have worries about your symptoms, or if you have worries about your medication, absolutely reach out and ask your medical team. I guarantee you that they have other patients who are asking those same questions if they are not asking those questions themselves, and they will be absolutely happy to answer them. You can also reach out to a mental health professional, whether it's a social worker, counselor, psychologist. The majority of us have transitioned our practices to telehealth, and we're right here with you. We know it's really hard. We're just as anxious as everybody else, but are absolutely happy to help and give support where we can. We want you to lean into coping strategies. So things that make you feel good, do them. Preferably things that are outside, a little bit of exercise. Building in those things to the day, even if it's 5 minutes of stretching in the morning, or a 10-minute walk in the afternoon, those things, when they're done on a regular basis, they can really not only boost our mood, but help us feel more in control. And make sure that we're connecting with family and friends. I think one of the hardest things about this is it's so isolating. And so really taking advantage of FaceTime and Zoom and phone calls and texts, all of those ways that we're so good at keeping connected, making sure that we're doing that on a regular basis is extra important right now. And then always lean into support. So CCF has great resources like the IBD Health Center, community website, Power of Two program, and then Facebook support groups too. Dan, next slide. So recommendations for parents of kids. This is a hard time to be a kid and a really hard time to be a parent. The biggest thing for families applies to kids as well. We want to keep them on a routine. Even if that routine is different than their school routine, we want to make sure it's as close to the same on a day-to-day basis as possible. I know there's a lot of pressure right now for homeschooling and getting the classes in and the coursework in. So I think, in case not enough people are saying this, we want to make sure that parents are giving themselves a break. If your child is safe and happy at home, you're doing a great job. If they're getting a little bit of learning in, that's awesome. But the push for productivity during this period of time when everybody is really stressed, it's not necessary. So, give yourself a break. If they have a routine, that's great. They have some consistency, that's great. When we're talking about kids, we want to make sure that they're getting the right information. So what we often recommend that parents do is ask them what they know. We want to know what kids know about COVID so we can correct those mistakes. And we want to know where they're getting their information from. Are they getting it from their friend that just texted them? Are they getting it from the news? Are they getting it from social media? We want to give them an opportunity to ask questions. So we often ask kids, what are your biggest worries about this? And then answer in a way that's developmentally appropriate. So we're going to give a different answer to a 5-year-old than we would a 15-year-old. And the way that I generally have parents do that is just by changing the amount of details you give. It's also okay not to know the answers to their questions. So one of my favorite things to say is, I don't know that. Let's look it up together. Let's see if we can go online and do the research and get an answer for you. We want to stick to facts instead of those big, scary ideas. We want to make sure that kids feel safe. When big, scary things happen, it makes all of us feel unsafe. And so having kids really focus on the grown-ups in their life that are keeping them safe, that are there, and then the things that they can do themselves to keep themselves safe. So washing their hands, keeping 6 feet apart from friends, using their elbow as a cough pocket, all of those things are in their control. They can use them. Those are strategies that a 5-year-old can use just as well as a 15-year-old, and can help them feel like they have a little bit more support and control in the situation. And then always reach out for other kinds of family-friendly coping strategies. So meditation, there's great yoga on YouTube, child-friendly yoga, art projects, any form of exercise. Really think creatively, and you can do things with kids. Also recognizing that most parents are balancing childcare and work right now, and so this is a time when it's okay to have the child play by themselves as long as they're supervised and safe. So really making sure parents, you're giving yourself a break, you're taking care of yourself, and your anxiety at this time is equally important as well. And I'm going to pass it on to Dr. Gurry.
Thank you, Rachel. Next slide, please, Sam. First of all, thank you for all the panelists, CCF, Dan, for arranging this, for being here, and thank you all for the participants who are here. This is unusual times, bizarre times, but we are trying to make the most of it. We're having to adapt in new ways for education, for information, and it's important to support our patients who are going through a lot at this point of time, and thank you for joining us. I'm talking about our essential workers because majority of the workforce of America has come to a ground halt. Not everyone's working, and of course that creates a lot of anxiety about your job security, about being laid off, is what's going to happen in the future. We don't know, but there are a lot of workers out there who are absolutely are necessary for the day-to-day functioning, which is a backbone of America at this point of time. A lot of them are working from home, and kudos to that for people who are able to make those arrangements. But at the same time, those who are physically going to their work locations, like for our healthcare staff or nurses or respiratory therapists or physical therapists, the doctors, some of those critical scientists who are actively working on COVID-19. We have some virologists in our own institution at Mizzou who are actively working on some of the research that's cutting edge on stuff like, is the virus going to spread through sewage waters and what have you. So that's kind of, there's a lot of work going on there, and how do they protect themselves? So it's depending on the kind of job you're involved with. Obviously, if you're in healthcare, the chances of getting exposed to COVID-19 is higher. So if you're a nurse, a doctor working with actively infected patients, obviously you have to make sure that you wear your protected equipment, your PPEs, your personal protective equipment. There's a lot that is being made available by the government, by the hospital institutions, and making sure you follow all those necessary precautions that you have to. The washing of hands, the social distancing as much as you can, a face mask, eye goggles in certain situations, and what have you. What about the risk in general due to therapies? I would say talk to your doctor who is involved with your care. The final decision should be coming from them. Of course, this is a two-way conversation. You could provide your doctor information that the doctor may or may not have, or that you could ask your doctor for information about certain concerns that you have. And this for workers who are involved in interacting with people, going out there. If you are on treatment, if there's a way you can stay at home and work, that's something you could potentially bring up, and your doctor may be helpful in getting you some documents, some kind of a letter that'll help you support, to work from home, like, telemedicine for some of the physicians who are out there, where we physically don't have to go to a clinic to see patients, to minimize risk for ourselves and also for our patients. So that's something that's made available by our institutions. Similarly, there's a lot of other software engineers who work from home, teachers who are working from home, students who are staying at home and getting educated, like Rachel was alluding to earlier. So that's something that you could definitely talk to your physician as well. Are there ways you can limit your exposure? Obviously, if you can avoid coming in social contact with other people, although they may be asymptomatic, but a lot of patients, unfortunately, have no symptoms with this COVID-19 virus. They are asymptomatic, and unfortunately they transmit. They could be infectious, and they could still be transmitting the virus. So of course, avoiding contact with people who are actively infected would be the best thing. If you yourself are having symptoms which are suggestive of a corona infection, then a COVID-19 infection, I would suggest you isolate yourself, get yourself tested. but also minimize your exposure to others as well. Other tasks you could do, of course, staying at home and working, things, keeping your personal hygiene and hygiene of other members in your family. Essential workers who work outside home during these times, and when they get back home, they're at risk for potentially exposing their own family members. And that's something that, bothers some of the healthcare workers. Some of the healthcare workers that I know are working from an independent home that they've rented out because they're working with COVID-19 patients. So yes, there are risks involved. So you have to try your best, and social distancing and, cleanliness helps. You're able to practice social work distancing at your workplace. Not our workplaces may allow that. So in that case, you could, potentially request for working from home. There is a resource available from Crohn's Colitis Foundation, an appeal letter for IBD patients who are on medications if they want to work from home through, telecommunication. They can produce this letter. Probably signed by their doctor or their work manager, and that should help them, work from home, give them an opportunity to do that. And do you have access to face masks and other personal equipment in your healthcare? That's, again, N95 mask would be ideal. A surgical mask is better than nothing. CDC, of course, came out with new recommendations that said even covering yourself with a face cloth is still better than absolutely nothing at all. Next slide, please. There's a lot of research that's currently undergoing for IBD patients who are who have acquired COVID-19 infection. There's a secure IBD registry that's initiated by, I think, University of North Carolina. It's called covidibd.org, and they're currently tracking how many patients with IBD are infected with COVID-19 across the world, not just in the United States. Of course, majority of those reported patients are coming from the United States. Last I checked, I think it was about 110, and I know the numbers are increasing. I know Dr. Rood has added some of those patients as well to that list. And the idea of having this registry is to figure out if there are a certain group of patients who are at risk for, among this IBD panel of patients, like, are patients on steroid more at risk than patients on immunomodulators? Are there more risk than patients on biologics? Our best guess at this point of time, like Derek earlier mentioned, was patients on higher doses of steroids, patients on immunomodulators, based on our pandemic data from the SARS 2003-4 era, the H1N1 influenza from 2009-10 time, suggests that patients on these high doses of non-specific immune suppression, meaning these are not very precise immune suppressing drugs like biologics, for that matter, like Remicade and Humira. They're more precise immune suppressants, versus steroids and immunomodulators are like more broad immunosuppressants, so they put you at a higher risk for acquiring infections. So there's a lot of trials that are underway as well. There's drug trials including chloroquine that Dr. Rood mentioned to us that are currently underway at WashU and a lot of other institutions as well. There is sirolimus interleukin-6 inhibitor. That's another drug that's being investigated as a potential therapy. Remdesivir is another antiviral drug that's currently being investigated. These are some of the drugs that have shown some promise, but we have no clear evidence or data to prove that yes, they work or they do not work. So a lot of stuff is still being done. People are being treated with immunoglobulin or antibodies from people who recovered from a COVID-19 infection, and some are showing positive results from that as well. And in terms of vaccines, currently we do recommend, if you've not had your flu vaccine or a pneumonia shot, it's not unreasonable to get it done. But in terms of vaccination for COVID-19, at this point of time, we have no clear sort of a timeline in place as to by when the vaccine will be available. There's a lot that's still being done from the Northeast and from China. There's a lot of data that's coming out about potential vaccines that is being investigated in animal models. And again, animal models have been hard to create in this disease because we don't, again, understand a lot about this virus. But yes, the researchers across the world, this has been unprecedented. There's been extensive collaboration like we have never seen ever in the past. People are giving away their information that they collect without, feeling the need to be recognized. They're just sharing the information, which I think is excellent. which brings a lot of countries, researchers, and scientists together. I think this shows the unity of the science and scientific, teams in general across the world. Next slide, please. This is some of the data that we extrapolated from the COVID-IBD.org website. This is, again, as of April 6, 2020. As you can see, the majority of the IBD patients who have developed COVID-19 have been the older group, usually 50 or higher. In terms of what type of IBD, is it ulcerative colitis, Crohn's disease? I think we saw pretty much a balance in both, from what I understand. Of course, a lot of questions that some of my patients ask is like, doc, okay, fine, I get at COVID-19. What are the chances I'll end up with a bad infection? Like, will I just have a flu, or will I end up with a ventilator, having a bad pneumonia, or what we call as ARDS, which stands for acute respiratory distress syndrome, which is a bad outcome from a COVID-19 infection. And of course, the worst of all outcomes would be the risk of dying. And these are, as hard as they sound, these are realistic questions we have to face and we have to encounter and respond to. In terms of the data that we have so far, and based on a little bit of calculations that I did, the overall sort of risk of death rate across the world in terms of infected patients is about 5%. Unfortunately, that's a very high number for a disease that is actively spreading. And this, of course, number is skewed based on the ones who have been tested positive. Of course, there's a lot of patients who are not tested who probably carry the disease. So we expect the number in reality to be somewhere around 1 to 1.5%. In terms of, based on the data that we have, the limited data, like I said, from this website, ulcerative colitis and Crohn's disease. Ulcerative colitis seems to have slightly more higher propensity to cause patients who have a diagnosis of ulcerative colitis and are in treatment seem to have slightly higher propensity to have a chance of getting intubated and being on a ventilator, or risk of further bad fatal outcomes from it, compared to, say, Crohn's disease, which seems to be more closer to the average population. But again, let me remind you, data is skewed by the fact that only the ones who are tested are your denominator. So this is something that we cannot completely rely on as a true absolute number, but it just suggests that there's some propensity towards a certain group than the other. And next slide, please. Dan, next slide. Yeah, in terms of more information that's out there for our IBD patients, I'm sure you guys love the Crohn's Colitis website, and they're very active with updating information. And Crohn's Colitis Foundation has, of course, updated their website for COVID-19 as well. And there's a link out there. Feel free to explore. Some other resources where you can get more information is the World Health Organization website, the CDC website. I'm constantly checking it every day to see if they have any updates, because you want to get your information right, like Rachel was mentioning, like Dr. Rood, and I think Derek kind of alluded to as well, that it is important to be appropriately informed. There's information, there's a lot of information. Unfortunately, that information can create a lot of anxiety, but the reality lies somewhere hidden in all that mixture of information. So getting it from the appropriate sources is very, very important. So talk to your doctor if you have more questions in this regard. Of course, we have our website to answer more questions. We are available today here for that very reason. And with that, I think we will turn to asking more questions, Dan. And thank you, everyone, for being present here. And we'll be available to answer more questions for you. Here's some of the links that are out there from Crohn's and Colitis Foundation. They have online support groups. I think just like what we are doing today, there is online support opportunities for St. Louis group, Kansas City groups, for the kids who have Crohn's or colitis as well. And yeah, the Midwest Pediatric IBD group, and also in Southwest Missouri, Springfield area as well. Thank you.
Thank you, Dr. Gorey. And I know I'm going to start with one question that I think is on a lot of our minds. How are the healthcare systems in your communities holding up with this surge in patients? Dr. Eckley, do you want to start with Omaha?
Yeah, we had an update about a week ago from our infectious disease doctors that have kind of looked at kind of numbers in the state. So their rough projections are about 70 to 100,000 cases in the state of Nebraska. And looking at it, our state population is like 1.6 million. Of those patients, about half of them or more will be outpatients. They're looking, kind of predicting based on what's going on thus far. Maybe about 5% of them will require hospitalization. So it puts a number about 4,000 to 5,000 of that. Initial population, about 1% of them may require ventilators. So that puts us about 1,000 patients. University of Nebraska, we actually have, it's about a 500 bed hospital. We have 77 ventilators. So you can see how quickly the resources can be outstripped. And that's kind of the big premise of flattening the curve and the social distancing, and hopefully reduce that burden up front and have the resources available. Kind of early on, we had some good testing that we had developed. Some of our microbiology, pathology physicians developed a test at Nebraska. So we had early testing that we were able to employ, and then we've expanded that with some of the other tests that have been available. Again, we're moving everything towards telehealth. I've been doing telehealth the last couple of weeks, so not really coming in contact with patients, but still being available to answer questions and kind of updating patients. UNMC developed a means of decontaminating N95 masks. So I know that the big question is what about personal protective equipment for our providers? And they're looking at being able to decontaminate the respirators with use of UV light. It's been used in other premises. It's been well studied. So, you know, in terms of having availability, I think we're doing a little bit better. In terms of where we at in the process, we have about, I think the last that I checked, we had 417 cases in the state. A lot of them are in the metro areas, kind of like elsewhere. And I think they're predicting the surge in the next couple of weeks, and they've been expanding, and they've even asked humble old me to even get back into hospital medicine to kind of help offload some of the work for our internal medicine doctors. So contingency plans are underway.
Dr. Ruud, do you want to tell us what's going on in St. Louis?
Sure. Interestingly, in St. Louis, there's now a consortium between the three major hospital systems in St. Louis to work together, which is probably the first time that's ever happened. And so that if one system gets overridden with patients, one of the other two systems will pick up some of the slack. We have currently 62 patients at Barnes Jewish Hospital with COVID-19. Approximately 27 of those are on ventilators. There's an additional 30 patients that are patients under investigation who are thought to probably have it, but the testing hasn't come back yet. We are doing everything to keep our manpower up. We have, in that it appears that kids are less apt to get sick with COVID-19. We are now transferring some patients over to St. Louis Children's Hospital, where they have the same ventilators we have on the adult side, and trying to offload that way if we need to. There is manpower deployments in various stages where we also are going to have to pick up the slack for our internal medicine intensivist colleagues. If and when the surge occurs, we expect the surge to be here in the next 5 to 10 days. So we're in it for a while here. Modeling, at least what I heard in the division-wide conference today, is we are probably closer to Washington State than we are to New York City, which is a good thing for us. We only right now have 106 ventilators in Big Barns, as we call it. That's not including, as far as I know, using the anesthesia machines in the operating rooms, which we will turn to if we need to. as we're not doing anything elective at this point. Anything elective is pushed, right now is pushed almost to June in preparation for the onslaught. So we're trying to keep everything lean and mean. Telemedicine's the way to go at this point. We'll go from there.
Great. And while we're hearing from the physicians, the patients are welcome to type any questions into the chat box. Dr. Gorey, you want to tell us what's going on in Columbia, Missouri?
Absolutely, Dan. So in terms of a lot of things that have already been mentioned have kind of been implemented in our institution too. We have this tier system where we advance from level 1, level 2, level 3 tier based on the number of patients in the community. Once we crossed more than 5 patients, we were at level 3 tier, which is the highest tier of contingency plan for the institution at large. So obviously, Columbia being like a Mizzou campus in general, there's a lot of undergrad students. They all were sent home. So the population in Columbia right now is really plummeted. I feel there's already not a whole lot of people out there because of social distancing. Now there's like college kids are gone, so it's like pretty much, I don't even know how downtown is looking like because I've not even been there, but I'm sure it's going to be pretty deserted. Apart from the fact that the university at large is making all these steps, a lot of our classes are online, student lectures online. It's very interesting. Thankfully, no Zoom bombing happened with us, but I heard that's been a thing happen in a couple of our other colleagues' classes. It was very interesting, but apart from that, in terms of health care personnel, I belong to a part of a COVID-19 contingency plan of doctors, just like Derek mentioned, and Dr. Ru did as well. So they'll have me test my medicine skills again, back in the ICU, back on the floors, and hopefully I can survive the rounds again. And apart from that, also we have established a drive-through testing center. I'm sure other institutions have that as well. The one in Columbia is located at the Hearns Center, where the baseball field is. And yeah, it's a drive-through center. You just drive in, and so it shows you directions. You get yourself tested. That way, the idea is to minimize patients and patient visitors coming to the hospital, getting exposed to healthcare personnel at any potential opportunity. Clinic visits are almost down to nothing. Colonoscopies, there's absolutely no screening colonoscopy. And it's very interesting that during the month of March, which is Colon Cancer Awareness Month, it was one of the most bizarre situations where we had to say, please, this is not the time for your colon cancer screening. Please hold back. It was a very bizarre sort of a thing for me to call my patients and say, yes, I know you need your colon cancer screening, but today's not the day. This month is probably not the month either. But again, having said that, hopefully once this clears out, I'm sure we'll catch up on all our patients. But at this point of time, we're looking at the big picture, and hopefully we've flattened the curve enough so that the cases don't peak to the extent that we suspect they will. Thank you, Don.
Rachel, how are things in Cincinnati?
We're hanging in there. I work at Children's Hospital, so our caseload in terms of number of positive cases has been fortunately quite low compared to our adult colleagues. That said, our hospital, like every other hospital, is bracing itself and making sure that employees are prepared. Our department, psychology, has shifted all of our resources to telehealth. So we're able to actually provide more care, but without risking providers and patients coming in for services. So everybody's flexing, and the city, from a healthcare standpoint, is moving more towards what was described before. So drive-through testing, testing is becoming a little bit more expedited, which is great. And there are more than one. There's more than one avenue to get testing for IBD patients specifically, so that's become helpful too. So I think they're anticipating our peak sometime in the next week or so. So hopefully, fingers crossed, we're prepared and equipped, and everybody's jumping in and wanting to help and be involved. So the collaboration has been really scary, but exciting to be a part of.
Thank you guys for telling us what's going on in your communities. I'd like to start with some of the patient questions that were sent to me before this event started. I'm looking at going back to work part-time with personal protective equipment. Does that lower my risk enough, or is it I should absolutely never leave the house? Dr. Ruud, would you like to answer that one?
It depends what your job is. If you are working in the emergency room, the intensive care unit, a COVID-19 unit, probably not a great idea. If you're in a low risk situation, then I think it's reasonable. But you know, we can't mitigate the risk entirely. But at this point, we have to do our best to try to isolate ourselves when appropriate and under reasonable conditions.
Derek, why don't you take this one? My husband is an essential worker, so there's a chance he could infect me if he got it before he was symptomatic. What precautions should we take?
Yeah, this is a tough question. Part of it is depending upon what is defined as essential. I mean, if it's another healthcare provider, you're definitely kind of put into harm's way. But there's been other essential workers that are out there as well, and other avenues that we can't do without. So part of it depends on what the risk is and what the exposure is. You know, we've had these hard conversations or difficult conversations in our family as well, because if I am called into work and become exposed, what does that mean for coming back home for myself and for my kids and wife? I think some of the premise that Dr. Ruud talked about earlier, the social distancing, ensuring that whoever the essential person is that's out there is wearing the appropriate PPE if it's available. A lot of discussion has been on in the hospitals or at kind of other institutions of going to work in a set of clothes and changing once at work and then changing out of those clothes. You know, practicing good hygiene to where you're washing yourself before coming home. I think the other consideration would be once getting home, you know, jumping in the shower if at all possible. If work has a shower to get into before you leave, I think all the better. And again, just good hand hygiene, making sure you're protecting yourself or the one that's out there working is protecting themselves as best as they can. Like Dr. Ruud said, we can't 100% mitigate the risk, but if we can reduce it as much as possible, that's kind of what we're shooting for.
Okay, Dr. Gorey, this question is, I have Crohn's and take Humira. I take a multivitamin and have been taking extra vitamin C and a probiotic. Any other recommendations to boost my immune system?
Right. In terms of protection against COVID-19 per se, vitamin C or a probiotic has not really been shown to be effective, not that we know of at this point of time. If you want to just take a probiotic for Crohn's alone, the data is pretty clear that probiotics don't really help in either sustaining maintenance or helping with induction. So yeah, but taking a probiotic is not really that bad, and people take some yogurt and that's okay too. People take a dedicated probiotic, that's fine too. Vitamin C is a antioxidant. It decreases inflammation in your body, and it's a non-specific antioxidant to say, to say the least. People drink orange juice during flu and think that it helps, and there's really no clear data that says that's actually true. People have actually started taking vitamin D supplementation because there's some data out there that's coming out with regard to the COVID-19 pandemic that patients who have lower vitamin D, they seem to be slightly at risk for having a COVID-19 infection. So making sure that your vitamin D levels are adequate, especially in patients with Crohn's disease, is actually, I think, is pretty important. That if you're not taking a vitamin D supplement, please do consider, and especially if you know that your vitamin D levels are low, please go back to your vitamin D supplementation. Maybe talk to your doctor, get yourself tested, check your vitamin D levels, getting a little bit of sun, going out there, out for a walk, like Rachel was alluding to earlier. That's not a bad idea at all. Yeah, and any other supplements, I would say turmeric has been shown to have some anti-inflammatory properties. Being an Indian myself, I do use that in a lot of my cooking. And does it have any effect against the virus? No, nobody knows. Again, a lot of this data we do not have. This virus didn't even exist until 3-4 months ago. So you can imagine the lack of information we as scientists and medical practitioners have in general.
Okay, Dr. Rood, this one will be for you. Should I be sanitizing carry-out food containers, and can I eat apples, nuts, and other raw foods I get from the grocery store?
Good question. Certainly anything that's raw that you get from the grocery store that is not something that isn't packaged probably should be washed. So I've even seen some people say it should be washed with soap and water. As far as wiping down your containers, I think that's probably not unreasonable. How much it'll do, we just don't know. We don't, there have been some studies saying how long the COVID virus will be able to survive on what we call fomites, which are, utensils and packages and it does survive for hours at least. So that probably a good idea.
Thank you for that. Let's give this one to Dr. Eckley. Can it live on my mail? Can I touch the mailbox?
Yeah, kind of an appropriate question. I had talked to my neighbor across the street, and he asked the exact same question really recently. So I think it's on everyone's mind. Kind of going back to what Dr. Rood said earlier as well, people have looked at it, people have studied it. I've seen different things where people say 3 hours. Some people say a cardboard, it can live for 24 hours. But it's also the different temperature, humidity scenarios that were kind of looked at. I would say in general, the CDC has come out, the WHO has come out and said it's a very small risk. We really can't quantify. No one has been reported to have received a package, and from that package, that's how they contracted it. I would say the majority of mail that's out there has sat stagnant or sat still for a prolonged period of time. So I think your risk is minimal. I guess it's always good if you're expose yourself to something outside after you open your package, making sure you're washing your hands thoroughly, not touching your face after or touching some of the external stuff, food containers, mail. I think that those would be good recommendations, but in terms of what's the overall risk, it's really difficult to quantify.
Okay, Dr. Gorey, would you mind taking this one? I was recently laid off. Are there any programs that you know of to help cover the cost of my treatment while I don't have any health insurance?
Sure. This is true for patients in general who are not able to pay for their biological therapies, sometimes even other medications. A lot of these drug companies will offer free therapy. The big ones out there are Janssen, Takeda, and AbbVie. They all have their free drug treatment programs. Pfizer for tafastib as well. I've had some of my patients get into these programs, and they're pretty helpful. They usually up to a year supply is really not a problem. Hopefully by then you can get your employment back, hopefully your health insurance back. I'm sure you're aware of the $2 trillion package that the government is releasing. You should be eligible for, getting some of a form of social security check, or so to speak, from IRS. You can look into that if you've not already received it. Yeah, so there are some free drug treatment programs, and our hospital itself, provides free treatment for an indigenous population, and so I'm sure other institutions do too. Sort of like for patients who are not able to pay for their healthcare needs at this point of time.
Rachel, let's give this one to you. I want to stay connected to my friends and family during all this, but people text me and the issues show up in my social media feed. It feels like I'm being constantly inundated with bad news.
Yeah, I think this is a problem that we're all facing right now. The biggest suggestion that we have is setting some boundaries for yourself and for people who are texting as well. We have had patients who decided that they are not going to respond to texts that are about COVID. I've also had patients who've been able to say, whether it's a friend or a partner or a brother or sister or a parent, that this is making me really stressed out. And if you want to talk about it, that's great, but please avoid sending me things because it's making me feel even more upset about the situation than I already am. In terms of social media exposure, the biggest recommendation is the same as news. We got to limit our time on it, which is really hard, given that so many of us have more free time right now. So I would limit it, and whether it's limiting it by setting a limit on your phone or setting a specific amount of time that you're going to look at it, over lunch, and then it's going to be it for the day. You can also set filters on social media. So if you don't want to see articles by this or about this, you can usually set those up as well. The biggest thing is it is so much more helpful to spend that hour outside or reading a book or even watching your favorite Netflix show than sort of scrolling through all the stats, because after a while, that information is going to be less helpful, it's going to be less clarifying, and it's going to be more overwhelming.
Thank you, Rachel. Let's give this one to Dr. Eckley. I'm worried I'm going to have a flare right now and have to go to the ER and be exposed.
Yeah, I think that's a concern for everyone, us included. We don't want you to kind of have to deal with those things. We'd like you to be under good control regardless of the situation. I think it's more acute, and we're more keenly aware in this situation. You know, I would like you and want those patients to avoid the ER as well, because, you know, that's kind of the worst case scenario. You know, we talked about limiting our availability and of performing colonoscopies, and I think a lot of us are going more towards trying to figure out if this is a flare by blood work or stool studies that we've relied on in the past. And I think it's something that we would, you know, hope if you're on a biologic, checking drug levels, can we dose escalate, optimize those medicines, and hopefully mitigate the risk or get on top of things quicker, rather than you flaring and requiring a hospitalization, requiring steroids to control this. I think that would be the worst scenario, or the scenario that we're trying to avoid, so that, you know, we're reducing the risk of you being in the hospital and having exposure.
Thank you. Let's give this next one to Dr. Rude. How much are the physicians ordering COVID testing based on GI symptoms? If new diarrhea, are they testing automatically or waiting for fevers?
I think it's variable based on where you're at. It is harder to get it here in St. Louis. I had a patient who had a fever, has Crohn's disease. Fever was not in the general scheme of what their Crohn's disease symptoms were. Went to their primary care physician, and they did not get tested, whereas I probably would have tested that person if I could get it. Problem is the testing is not universally available, and it's still being triaged. So it's a hard decision to make. I think if you have a fever and GI symptoms, you get tested. Without the fever, it would be very difficult to make a cogent argument that you should be tested unless there's a cough and some other respiratory symptoms. I don't think you're going to hit muster as far as getting into anybody's testing at this time anyhow. Now, I think the other thing is we don't know what the denominator is. And until we come up with widespread antibody testing, now what antibody testing is, it will tell you whether you have been exposed to COVID-19 and mounted an immune response against COVID-19. Once we get that, and there are antibody tests out there that just are not widely available, we'll have a better idea of what the denominator is. Because right now, you know, there's so many people who are asymptomatic or not very symptomatic that have had it, a mounted immune response, got over it, and we don't know who those people are.
Dr. Gorey, this one will be for you. Can you speak to community immunity? Is some subtle interactions with COVID-19 in the community creating some antibodies that can help our patients?
In terms of our herd immunity, Dan, is that where you're alluding to probably?
No, it sounds like they're asking if low-level exposure to it is a good thing for creating some antibodies without getting sick.
I would say the way the coronavirus has been behaving, it's essentially there's a group of people who are at risk for having the COVID disease. Remember, the virus itself is called a SARS-CoV-2 virus, and it causes a disease called COVID-19. COVID-19 can lead to a complication called ARDS, which is a bad form of a pneumonia, which makes them end up with, getting intubated into a ventilator. So there are different severities in which this disease, the infection manifests. People can have as mild flu-like symptoms to just a mild headache, just like a GI bug comes and goes and people define a mild fever, or they could be asymptomatic. A person who's asymptomatic could transmit the disease to someone else who could have just flu-like symptoms, who could transmit the disease to someone who ends up with ARDS, ends up in a ventilator, may recover from it, transmits to someone who comes into the ER and is dead. So I would be very careful how we implement these strategies of, herd immunity, of, community immunity. These words seem to sometimes mislead. I think this information should come straight from CDC alone or from federal government regarding how this needs to be addressed. Multiple models across the world, like in South Korea, United Kingdom tried to follow the herd immunity model, and it was a big failure. And now they're close to 40,000 patients, and they're climbing. Their own prime minister is in the hospital. So this is something that if we had known how this virus behaves, like say in case of influenza, we go for the herd immunity, we get the influenza vaccine, and people tend to do okay after that. But this is a very novel virus, and the pandemic is exponential. Never have we come across this in our lifetimes, for most of us. So I would be very careful about community immunity would be the way to go. Now, in terms of vaccine development, I kind of mentioned already, there's nothing in foresight right now, but there are plans that maybe within 9 months, 12 months, people are trying to give some vague numbers into by when we could have a vaccine. But of course, our IBD patients are at risk for having a higher risk of, so to speak, of acquiring the infection. If you get exposed to the bug, the chances of you having a COVID disease out of it is probably higher than your average patients who are otherwise healthy and whose immunity is 100%. In terms of what other risk factors you could have if you get exposed to the virus and end up with the disease itself, being obese, unfortunately, has been linked to it. Male gender itself, is it because of the comorbidities, or is it the gender specific? Nobody knows. This talks about hormonal protection for women, but again, there's really no data. We're just going by numbers that we have. Having high blood pressure and being on medications like ACE inhibitors have been associated with high risk of getting the disease if you get exposed to the virus. Patients who are smokers, and this is again goes back to our IBD patients. As you're aware, Crohn's disease gets way worse if you're smoking or you're an active smoker. The complications that come from it are severe. So this is another opportunity that we probably have to quit smoking. Patients who have respiratory illnesses like asthma or have smokers' lungs like COPD. These are all patients who are very, very high risk. Patients whose immunity is compromised, like patients on high doses of steroids, patients on chemotherapy. In fact, in our infusion center, we have actually segregated our patients, the patients who come for an infusion for, say, your IBD treatment, like Remicade or Entyvio. They come at a separate time compared to our other infusion patients who come for their chemo infusions, because they're so immunocompromised. You don't want them to come in contact with anyone. So it all depends on what risk factors you're carrying. The more the risk factors, the chances of you having a COVID disease goes higher. If the risk factors are furthermore adding, the chances of you ending up with a respiratory failure or ARDS pneumonia goes much higher. That's pretty much how I would like to frame a response to that kind of a question.
Let's give this one to Dr. Eckley. Will warm weather affect the spread?
That's kind of the premise that people have been talking about, that hopefully with the warm weather, the humidity, that the transmission will kind of go down, as we've seen in influenza. Other people are talking about this potentially going on for months on end. I don't know that we completely fully understand it. Talking with our infectious disease doctors, I think that they're a bit more worried about it. We don't know. I think once we start to see that plateau, I think we can take a big sigh of relief that hopefully this is it. We just don't know. I think some of the alarming things are we going to see a second peak in the fall, like we do a seasonal flu where it's comes and goes over and over? I don't know. I hope for the best. I pray for the best, that this kind of comes and goes, but yet to be determined.
Okay, this one is for Dr. Rood. He stated the virus or the body's reaction to the virus is causing an increased risk. What is your hunch? What is causing the issues?
It's a good question. I don't know that anybody knows, but that was something that Tony Fauci talked about in the last couple of days. Where is it a hypervigilant reaction by the body to the virus? And that may be one of the ways that hydroxychloroquine works, because hydroxychloroquine is an immune suppressant. So that's at least one of the theories behind that one. I don't know that anybody knows that at this point. Just want to make another comment on an aside. Just because you have IBD itself does not, as far as we know, put you at risk. It's the medications we use to treat IBD that put you at risk. I had a patient ask to get a letter so he didn't have to go to work, which was fine, but the patient was not on immune suppressive medicine. So, the data is the data. So that's that.
Okay, this one is for Dr. Eckley. He mentioned SARS back in the early 2000s had complicating factors in patients on steroids. What were those complications? What were the outcomes?
I don't know the specifics about it, more generalities of people that were on immune suppression and steroids tended to get more ill or have more complications, similar to what we're seeing with the coronavirus as well. So, we're kind of basing our information on the fly because we're learning about this kind of on a daily, hourly basis. And we're kind of looking back to the Middle East respiratory syndrome, so MERS, as well as SARS that was earlier. And some of the things that we were seeing then, we're seeing now. And one of the risk factors was immune suppression with steroids, having more complicated cases. But overall numbers, what were the outcomes? I don't know that off the top of my head.
And this one will be for Dr. Gorey. What are the recommendations if patients are flaring, but we're not able to scope to assess? Should we do steroid bursts or go ahead and adjust biologic according to symptoms?
And I've already encountered some of these situations with my patients already. First, like I think Dr. Eckley mentioned, would be to assess if someone's flaring, to confirm the flare. Blood work, stool studies are pretty good. Sometimes maybe even imaging may not be unreasonable, but there are some institutions which have like dedicated radiology units where you don't see a lot of patients with other illnesses go there. So the chance of you getting exposed to someone who has a respiratory tract infection is going to be much lesser. That's not a bad option. Once you've confirmed that there's a true flare, if you are on an existing biologic, I think that's the best situation. Then you would just adjust the dose of the biologic based on the drug levels, if you have the drug levels already, or get the drug levels and then adjust the biologic dose, like say for Humira, Entyvio, Stelara, or Remicade. What's interesting is, and I've had some of these situations come from some of my colleagues where they ask me, so this is a new patient who's flaring, they need to be on a biologic or should they not? And if so, which one should I start? And that's a difficult sort of a situation. And it's like, well, they all are immune suppressing drugs, which one's better? But I think it would be safe to say Entyvio would slightly be considered more safer than say Xeljanz, which is slightly a higher risk for possibly causing a viral infection. So that's one clear sort of expert opinion that's coming out there. In terms of other biologics, it's out there. The policy that I am following is, if I'm going to start a biologic, and if they can take the biologic from home and not have to come to an infusion center, I think that's still a win. So maybe Entyvio, sure, not a bad idea, but the downside to that is you have to make visits, frequent visits, because your induction doses are 0 to in 6 weeks. So you come frequently to the infusion center, you're at risk for getting exposed. Versus say Humira or Stelara, where in Stelara you get one infusion followed by sub-Q shots at home, where they get delivered to home and you take them at home. The chances of getting exposed to a healthcare facility is minimized. Same with Humira, you take your shots at home, you don't have to really go to a healthcare facility. So there's a lot of nuances to this. You kind of have to make an informed decision with your IBD specialist or your GI specialist who's managing your care. In terms of selecting other drugs, steroids could be used if there is a need to, and steroids are effective drugs in terms of controlling flares, but as a temporary fix, and that's something that you have to be aware of. Do you have other risk factors? Do you have other lung-related problems? Are you an active smoker? Have you recently had chemo for any other reason? So there's a lot of other factors you have to kind of come into play, kind of like I mentioned earlier about risks of getting a COVID-19 disease, and based on the risks, determine if that's the way to go or not. But I think another thing that's probably clear is staying away from immunomodulator drugs like methotrexate, 6-mercaptopurine or 6-MP, and Imuran or azathioprine. These are pan-immunity suppressing drugs which can suppress your immunity at multiple levels, and we don't know exactly through which process the SARS virus, the COVID-19 virus works through, but these medications will suppress all aspects of immunity. So whichever pathway it's taking, it will definitely be compromised. So, yeah.
Let's give this one to Dr. Rood. I have a nurse that comes to my house once a week. I assume she's going in other homes and helping people and potentially exposed. What can I do to limit my exposure through her?
Well, I think you go through the same thing that we talked about earlier: washing hands, wearing mask. Both she would wear a mask predominantly to risk not getting from her. She would wear the mask. I suppose you can wear a mask too. Beyond that, everything has its risks and its benefits. If the need is there for nursing home visits on a weekly basis, then you have to balance it out versus the risks involved in having somebody from the outside come in. Sometimes the risks are more than you'd like to accept, and if the need is not acute, maybe go without. It all depends on the individual situation. So, our nurses are wonderful. They do their best that they can. Good hand washing, all those other things need to be done. But you cannot mitigate the risk down to zero, though.
Okay, let's give this one to Dr. Eckley. Do we know how or why COVID-19 acts initially on the gut in some and in the respiratory in others?
Unless my other colleagues have a better answer, I don't think we know specifically. I think Dr. Rood had alluded to it earlier, and I've heard it in other areas as well, is if we had an antibody test, or if we were doing a better job from an epidemiologic standpoint of the point that they're tested, if there's also symptoms. So listing the symptoms that correspond to the positive or negative test would also help us determine who's getting it, who's not, who's been exposed, what were their symptoms. And not in all instances are we getting that data. An antibody test would be monumental to help us explain, hey, 2 weeks ago I had what we call a GI bug and diarrhea. Oh, that was my coronavirus. We don't know. The other complicating situation is the sensitivity, or how good does the test do at predicting or determining positive or negative infection. Some people have reported it to be about 70%, and there's various versions of the test, and those numbers are going to be a little bit different from one place to another, but we're potentially missing cases that are positive, that are presenting to us, that for all intents and purposes look like coronavirus, but then test negative. I think the preponderance of evidence at this point in time is, if the one case in Nebraska that I know of was, again, a respiratory viral panel negative, influenza negative, and coronavirus negative. So they were ill with something, and what is it exactly, I don't know. So it's really difficult to tease out who gets GI symptoms, who does not, who's mild, who does not. We do not have a good handle on kind of the epidemiology from the beginning of this pandemic until the present. So it's multiple permutations from China to Europe to us. It's a work in progress. And I would open it up to the other colleagues if they have any other comments.
Here's one for Rachel. Are there any tips you can give for your patients who are working or schooling at home?
Yeah, it's really hard. Keeping a good routine and schedule. So going so far as actually mapping out when you're going to get up, set an alarm, set reinforcements. Don't have an expectation that you're going to get as much done at home as you would at work. It's probably not feasible. And set break times. For our little kids, we call them wiggle breaks. Grown-ups can call them that too if you want. But it really means setting a realistic amount of time that you're going to sit and work. For most of us, that's about 30 to 45 minutes that we're going to be actually productive. And then plan to take a 15 to 20 minute break. So really structured schedules. Obviously for kids, we're going to scale that back. So teenagers, we would give about 30 minutes, 30 to 45 minutes. School age kids, we're going to max out around 30 minutes. And then we're going to add in a break, and then we're going to get back to work. I would also set up opportunities to work and learn in different settings. So if you have any outdoor space, work outside for a little bit. Any chance that you have to break up your routine while still being consistent with the day-to-day activities is going to be good for your mood overall, but is also going to be good for productivity.
Thank you, Rachel. I've been actively seeking out good news, and today I heard that the baseball season may begin in May, and all the players might play from one site in Arizona with no fans. So that's my tip, is to look for some good news. I think we've concluded the questions that patients have for this evening, and I'd like to give a few closing remarks. The Foundation's currently doing everything we can to answer patients' questions, including the COVID-19 section of our website that we mentioned in the slides previously. We also have an IBD help center that you can reach at 1-888-MY-GUT-PAIN. This center is getting a lot of calls right now, and I know some of the people that work the call center are staying on the phone with patients to offer them support for quite a while. So I'd recommend, if you're having questions, to reach out to them and give them a call. It's a very useful resource. As mentioned in the presentation, we've also taken the majority of our support groups online. It helps to stay connected to other patients and feel supported by one another. Normally, we hold these education events in person, and if you've never been to one, I recommend that you come out. We usually have lunch together and bring our families and get to talk with the physicians in person. I hope you all consider attending one. Another way to stay connected to the IBD community is to join us for Take Steps. This is a fundraising event for the Crohn's and Colitis Foundation, and many of the attendees tell us that they feel inspired by the collection of passionate people and companies that want to fund cures for IBD by participating. Some of our events have moved online to a virtual experience this year, making it easy and safe to participate from anywhere. We invite you to find out more and meet your local Take Steps manager by logging on to cctakesteps.org. I know it's a difficult time across the country, and it's also a challenging time for the foundation to continue funding research for better treatments and a cure, and to fund events like this one. Please contact your chapter office if you can make a donation. I know it's a difficult time for people and not everybody can do it, but any amount is appreciated. Thank you to our panelists. Thank you to Takeda for sponsoring this event. And thank you all for joining, and good night.
Good night.
Thank you. Good night.
Stay safe too.
Thanks, guys.
Okay.